that you come in. Just a minute. So I want to go over just a little bit today about what we're going to talk about. And Liz, I think I'm going to try to share my screen. We'll see how well this works. Great. Can everybody see that?
Yes, we have it.
Okay, great. So the title of our presentation tonight is Barrier-Free Healthcare. We want to give you some best practices for providing medical care to people who have disabilities. I'm sorry, I do not do PowerPoints very well. On the next slide, I have a list of our presenters, including myself, with our information to get a hold of us. Our learning objectives tonight are the first one is working together to provide good customer service to people with disabilities and help you recognize discrimination in the healthcare setting. We'd like to provide you some examples of best practices in providing medical care to people who have a disability. We'd also like to provide you some tips on working together with partners in the community to remove physical, communication, and attitude barriers in the medical settings. And I'd like to also provide you some resources on the ADA requirements, which will be at the end of the slide. And I think Liz also has one of the PDFs that I sent with links into that to provide you resources. The topics we'd like to cover tonight are tips to comply with the ADA requirements. This is a federal civil rights law that provides protections to individuals with disabilities. We'd also like to provide you some examples of good customer service addressing disability etiquette and respectful language. Another area of topics we're going to cover is auxiliary aids and services that includes digital access to ensure effective communication for individuals who have sensory disabilities, such as those who are deaf or hard of hearing, blind or with low vision, and other types of disabilities. And finally, we'd like to provide you ideas on how to create an accessible and welcoming medical environment to accommodate individuals with disabilities. So I was in a training last week and I thought this slide shows some headlines about how uninformed doctors are. And I found that really kind of odd because, the ADA has been in, in law for over 30 years now. And one of the things that they found in a study as out of 714 U.S. physicians in outpatient practices, 36% of those had little or no knowledge about their legal responsibilities under the ADA. And I go, if you think about it, that probably makes sense because a lot of time, a lot of universities do not provide any information or classes on the ADA or civil rights laws. 71% answered incorrectly about who determines what a reasonable modification would be under the ADA. So, a reasonable modification to like a medical practices, maybe a person would take more time, a patient take more time because you'd have to communicate and explain things a little bit more longer, or maybe it takes longer to get on a table. That might be a modification. 20% did not know who was obligated to pay for accommodations. I cannot tell you how many calls I get from people who are trying to get access to doctor services, and the doctor's office does not understand that they have to provide and pay for maybe a sign language interpreter. And 68% felt that they were at risk for ADA lawsuits. And that's really unfortunate. There's so many of us out here that We are a great resource for you. So if you ever have issues or concerns or questions about the ADA or what your responsibilities are, we are here to help you to answer those questions so you are not at risk for ADA lawsuits. So I'm going to briefly go over what the 5 titles of the ADA are. And I'm not going to go into a lot of the ADA stuff because we have only, a short time, and I want each and one of you to get to know, to get information from our other speakers tonight. But the first, I'd like to go into the titles, and the first title of the ADA is Title I. And Title I, the federal Title I for ADA is if you have 15 or more employees, you must comply with the employment regulations of the ADA. However, Idaho law applies to private medical providers who have more than 5 employees. And it's not just medical providers. I just put this slide in there, or this information in there, to let you know that you must comply with Idaho state law too. And Title II has to do with public services, and it is state and local government. And the one that you want to focus on is Title III, which is a public accommodation, which is private businesses and nonprofit that would include medical practices and hospitals. And Title IV is telecommunication, that includes relay services, captioning, and a lot of that has to do with the FCC. And Title V is miscellaneous. So what is the purpose of the ADA? Well, as I said before, it's a civil rights law, and it prohibits discrimination against people with disabilities in all areas of public life. The ADA assures that we have the same rights and opportunities as everyone else. It doesn't give us a special right, it just gives us an equal playing field to have the same right and opportunities. And it includes opportunities in all sectors of access, inclusion, and opportunity. So, what are some of the basic principles of Title III? Well, what it says and what it means is for you to deliver services, it ensures all people equal opportunity to participate and achieve the full benefit of a program or services in the most integrated setting appropriate. So you wouldn't send people with disabilities to this special practice that only people with disabilities go to unless, it was like you're going to rehab. I mean, that's not a special practice. That gives anybody with different kinds of issues to go there. But you can't segregate us out from going to a healthcare provider. So, as I said before, that would be you'd want to make reasonable modifications in your policies and practices. You'd want to provide effective communication, auxiliary aids and services, and you'd want to also make sure that you have physical access to your goods and services. So, what are some of the other obligations? Well, as I keep saying, to avoid discrimination, we make adjustment to our rules or changes to your usual practices, and everything is determined on a case-by-case basis. As you know, not every person with a disability is the same. I am a quadriplegic. I have a friend that's a quadriplegic, but we do not need the same kinds of services, the same kinds of, our life is different, our disability is different. You also may not impose costs. So I explained that earlier. So, I get a lot of comments from different doctors' offices. Well, we're a small doctor's office. How do we pay for these costs? Well, you want to build into your budget, into your cost of the practice to do that. And you cannot charge a person more for their services than you can another one just because we need effective communication or changes to the way you do your practice. There are tax deductions and tax credits available that you can use when you do your taxes. There are some limitations. So at times that you do not have to provide certain types of accommodations or certain things if there is a direct threat, or if it's a fundamental alteration to your services, or if it's going to cause you an undue burden. But each one of those limitations are on a case by case basis. And contact me for more information and on these topics. And I've also included resources to help provide you more information. So what does effective communication mean? Well, that means communication with people with disabilities is as effective as it is with people who do not have disabilities. You want to plan ahead and have an idea on what kind of interpreters to contact. Have a list of those, and Stephen will talk a little bit more about that. You also, when you're looking at auxiliary aids or services, you look at the type of communication that that individual uses. And you also look at the nature, length, and complexity of the communication taking place. So, Stephen, I'm going to turn it over to you, and I'm going to stop sharing my screen. And Stephen's going to talk a little bit more about effective communication and some examples of what he's seen.
This is Steve. First, Dana, I do want to say thank you for introducing this topic. And I am thrilled and honored at this opportunity to be able to share with you as physicians here today. Understand I only have about 10 minutes to share. Normally when I provide this training for healthcare professionals, I have an hour and a half. So I will try to condense this down into 10 minutes, but please bear with me today. So a little bit of background about myself. Clearly, I am deaf. I am signing. And deafness has two components to it. So there is my identity as a deaf person and the medical diagnosis of that. And so my identity is cultural. And so I identify as a deaf person. I am proud of that fact. And I am a fourth generation deaf person. So this has been part of my heritage. I would like to briefly talk about our agency here at CDHH. Part of our mission is to ensure that our deaf and hard of hearing community throughout the state has a quality of life equal to that of other Idahoans. And of course, that includes healthcare. Healthcare is one of the most important parts of our job here. And as Idahoans, our deaf community needs access to that. Often within the disability community, we talk about physical access, but within the deaf community, we have to focus on our communication access. How do we get our information? Oftentimes within, if it's a physical issue, it's a one-time fix. We can fix the space or ensure that that area is set up. But within the deaf community, setting up interpreters or those costs, it's an ongoing challenge, and it is something that our entire community faces. I would like to share some statistics with you. Within the state of Idaho, we have an estimation. Normally I would ask for guesses from the audience, but because of time, I will share it with you that across the state, we have approximately 240,000 Idahoans with some degree of hearing loss. Approximately half of those are senior citizens. But you will provide care to someone who is deaf or hard of hearing. And a high percentage of our community experiences disparities within the healthcare system.
So for someone who is blind, you may feel a little bit awkward, but you can still communicate. For someone who's in a wheelchair, there's still communication access happening that you can go through and ask questions and reach healthcare solutions that way. But for someone who is deaf or hard of hearing, that can definitely feel like an awkward approach. And oftentimes it's a deer in the headlights type of thing. And so oftentimes providers are unaware of the requirements and how to go about the communication to provide the healthcare needs that that deaf patient has. And it really is unrecognized discrimination. So at CDHH, we partnered with ISU for a research project. And that research has been published about a year now on JAMA. If you're interested, that's wonderful bedtime reading. You can give me your email and I'll send you the link to that article. And that research is actually related to seeing if deaf community patients, the rate in which they can receive a new patient appointment compared to hearing patients requesting a new appointment. So the group of folks who are hearing and deaf, they were two separate groups and they called the same clinics to reserve new patient appointments. And a very large number of deaf patients failed to get new patient appointments at those same clinics that their hearing counterparts were receiving new patient appointments. And upon further analysis, they realized there were two reasons for that. Calls from a deaf patient are often used through an interpreter and then automatically given that we are not accepting new patients at this time. But a call from a hearing person was received, they were able to get that appointment. And another issue that we saw that through these simulated patients were denial of insurance. Is deaf folks got the reason that we don't accept their insurance, but their hearing counterpart using the same insurance were able to set up those new appointments. So it's fascinating research. If you really would like the link, please let me know and I'd be happy to share that with you.
I would like to share some of my personal experiences with you all. So as I said before, I am deaf and lived in a small town here in Gooding in Idaho. So maybe some of you know where that is, but that is where I grew up. And I went to my family physician for all of my needs at that time. And I called him the thumbs up doctor. So all growing up, I never had an interpreter. My parents would sit with me in the room. And the only thing that the doctor would do he would perform this examination and he would give me a thumbs up. That was all I knew when it came to my healthcare, was a thumbs up. When I entered high school, I became more curious. But even though I tried to ask questions, I was met with that same response, a thumbs up. I had no understanding of my own healthcare. Later on, I was able to use an interpreter, or I had an interpreter available to me, and I was able to learn more. Also, as a child, going to the dentist, I was always fascinated by the tools that they were using. I always wanted to know what it was for, and I didn't have a way to ask them until I lived in Maryland at DC when I was in college, and I had a deaf dentist. And I saw he was using the same tools, and I was finally able to ask all of my questions. So one example was a periodontal probe to measure the depth of the gum to see if there was gingivitis. And I was always curious what that tool was, what it was for. And finally, that deaf dentist was able to explain that process to me. And I was able to see how much I had been missing out, how much we as a deaf community have not had access to. These next stories are not my own, but they are stories that happened to our deaf Idahoans here in recent years. And they show just the disparity that is in existence within our healthcare systems. There are many stories, but I have whittled it down to 3. So one story is that a mother, she was deaf, her daughter was hearing. She saw that something was wrong with her daughter and took her to see their physician. There was no interpreter provided, and she was trying to explain what was wrong, but the healthcare providers said that everything was okay and sent her home. She saw that her daughter was not getting better, so she went back again and requested an interpreter, but again, they refused. They tried to work through communicating, writing notes and everything else, but they responded that they'd already given medicine and that it would be okay. Unfortunately, the situation escalated and the mother took her daughter to the ER, where an interpreter was provided. And finally, that mother was able to explain what she had been seeing all along. And the doctor was able to save her daughter's life. So that is one example of if the interpreter had not been there, what could have happened? Another story is a man who did have limited language, went into the hospital complaining of pain, but no interpreter was provided. There was a nurse that had remedial sign language, but not enough to communicate effectively. The man was put under, anticipating that they were doing just some more analysis of what was wrong. And it wasn't until after he woke up that he had realized that he had had an appendectomy. He had no idea that he was going in for surgery. He didn't understand what he was reading, what papers were being pushed at him to sign. He had no concept of what that was. And so when they gave him those papers to sign, he signed it, but he had no idea what he was entering. There's so many other stories of interpreters that are not qualified, that are hired and are not able to effectively communicate how often medication needs to be taken or what the procedures look like for that can lead to a variety of other issues. One thing that has improved over the years is that historically, it often occurred that hearing children of deaf parents, doctors would try to have the children interpret for the parents. Thankfully, and since we have passed an interpreter license law, the occurrence of that has significantly reduced.
So now with the requirements of having licensed interpreters, there are ways you can contact our office and we can discuss to give you different resources on how to get those appropriately licensed sign language interpreters in your offices that are local to you. Oftentimes, large hospital systems like St. Luke's or St. Alphonsus, they have their computer system, Epic, that has certain provisions on there that will alert when you pull up a patient's file when reserving an appointment that an interpreter is needed in what language is specified. So that is a really neat option to utilize for patient charting so that future appointments are made more seamlessly through the reservation of a sign language interpreter. Another drastic situation that we've all become way too familiar with is COVID-19 and the disparities that the deaf and hard of hearing community experienced during that, especially senior citizens and having to operate with masks and really struggling with the lack of facial cues and speech reading. And some folks have asked for the removal of masks for clearer understanding or using clear masks. But really what we're seeing is a lot of the community experience clinicians refusing to do that. Luckily, there were some folks who would. And for obvious reasons, there were reasons to have and to keep those masks on for the prevention of illness to spread, but definitely needed to look at what other options there were for communication. And like I mentioned, using those clear masks. So that was a big barrier that the deaf and hard of hearing community faced during COVID. And I really want to wrap it up. I don't want to take over Lane's time. So different ways we can solve communication barriers is one, through education and training. Our agency provides a more in-depth training. We will come and present to your staff, to your office, et cetera, on how to work with deaf and hard of hearing patients. And we will analyze your clinic's policies. Do you have policies in place and ready to employ when you have a deaf or hard of hearing patient? And that policy is great for if you have staff turnover, having that implemented so that with staff turnover, the new staff know what to do and how to handle and go about those situations. And really, I just want to emphasize that CDHH is here to provide resources and support anytime. We are welcome here for you to contact us. And now I will stop talking and I will hand the mic over to Lane.
Thank you, Steve. I always appreciate speaking after Steve. He really does a great job of setting the foundation for a presentation. And I'd like to, like Steve and Dana, express my gratitude and appreciation for everyone attending and Liz for coordinating this opportunity. Steve mentioned in the communication component of interacting with people with disabilities that blindness is not something that is really going to be a significant challenge to communicate through in person. You still have the opportunity to speak to people who are blind and visually impaired, and the oral communication is not going to be a significant barrier. So I'm going to go ahead and jump right over that and just jump right into a lot of the different components that make communication a challenge for someone who might be blind or visually impaired while partnering with their family physician. I'll start with one of my own anecdotes from the time of telehealth and COVID-19. My biggest barrier when working with my physician is related to online portals, scheduling through those portals, emailing through those portals, and when it comes time to do the telehealth appointment, actually connecting to the video conferencing. So the challenges that I face are more in the written and electronic communications phases of that interaction with the patient, with the provider. Those are all covered in terms of guidance. There's guidance from the Web Content Accessibility Guidelines issued by the W3C. There are great guides for procurement within that framework, so you can make sure that you're asking the right questions of your portal providers and making sure that those systems will meet technical guidelines and standards for access with assistive technology. As a certified professional in web accessibility, this is also where my expertise lies in testing those portals and any other digital asset, a website, a newsletter, any of those digital communications. I haven't met a family provider yet who relies on social media, but if in case you do, that is also another area where people who are blind or visually impaired may experience barriers in their communication with your offices. In the physical space, the only thing I can say is to please make sure to speak to an individual who is blind or visually impaired as you speak to anyone else. You don't need to speak more slowly or enunciate more clearly. And while you might be uncomfortable about a mobility aid, a white cane, or a service dog, for example, just know that those are tools that do not define the person. Stephen touched on two aspects of his experience as a person who is deaf: his identity and the diagnosis. The same is true among people who are blind or visually impaired. I have my community, my blindness community and culture and identity, and then there's the diagnosis that defines what those functional limitations might be. But know that whatever the diagnosis says about those functional limitations, I have more than likely established a tool or alternative technique to achieve the same function, just in a different way. I want to leave you guys with one other short anecdote, just to kind of drive home some of the experience as well, and make sure that our friend Joe has plenty of time. And he has a slide deck and a whole lot to cover, so I want to make sure he has that time. But one other personal experience with a family physician that I wanted to share, and I called his office yesterday to confirm I can use his name, because it was such it was a great example of both the good and the bad. My obstetrician is Dr. Darren Wyrick in Boise. I've worked with him for 15 years now for all kinds of things. And when I became pregnant in 2015 with my first child, his office welcomed me like every other patient. No questions about how I was going to care for a child. They had all of the paperwork at that time was pen and paper. Their staff were willing to make the accommodation to scribe for me. So they would read the paperwork and write the answers for me. And it was no big deal to them. It was like they do that every day for everybody. When it came time for my 20-week scan, I happened to be traveling to DC for work. So I missed the window to have the scan done in Dr. Wyrick's office. When I returned from DC, I had a scheduled appointment at another clinic to have the 20-week scan done to go over the basics, in terms of the child's health and gender and all the things. And in the scan, at one point, the nurse left without speaking to myself or my husband, who is sighted, and she returned with the doctor to tell us that there had been an anomaly on the baby's heart, a white spot. This doctor proceeded to encourage me to abort my baby. He gave the reason that this spot on the heart was an indicator of Down syndrome. Fortunately, I am tied tightly into the disability community, including many of the Down syndrome family support systems and networks. And I was able to advocate for myself, reminding him that this is one indicator, and that should not alone be a reason to terminate a pregnancy. He proceeded to tell me that regardless, I have a disability. So I shouldn't burden myself with a baby with a disability. Needless to say, I left, returned to see Dr. Wyrick in 2 weeks, very upset with how I had been treated. I left out the part where they were very upset that my guide dog was present as well. And they made me wait in the waiting room an extra 20 minutes so that they could decide what they were going to do with me. Left that part out. But the fact is, like, the whole encounter in that second office was awful, and I was upset when I returned to Dr. Wyrick. He took a look at the pictures and was able to reassure me that yes, this spot on the heart could be one indicator of Down syndrome, that I was right to advocate for myself and to leave the other office when I did. And he proceeded as though my pregnancy were normal. My son was born in August 6 years ago. He is happy, he is healthy, he has no signs of any disability, including the blindness that is hereditary in my family. So good and bad example of what can go wrong. And just that reminder to know and to treat everyone with respect, regardless of what the diagnosis tells you about a quote unquote disability. With that, I want to turn it over to Joe and let him jump into his experience as a physician and what that has looked like for him.
Joe, you're on mute.
I'm back. All right. And what I wanted to say was the three presenters or the three presentations prior to me, I think the information was invaluable, and I want to thank everybody for what they presented. It's going to be hard to follow that up. But I'm going to try and do a little kind of rapid breeze through solutions to physical and architectural barriers for persons with mobility limitations. Now I can't seem to, there we go. Okay, so the ADA guidelines were set, and they're defined as a minimum guideline set by the Access Board. I think you can speak with many people who are wheelchair users, and many of them will say that being ADA compliant does not necessarily mean accessible. And I think a lot of our environments that we encounter on a regular basis aren't easily accessible to wheelchair users. As for entrances, some of my experience, the doors within my facility are 35 inches wide, and many of the chairs that people are in, especially manual wheelchairs, because of the nature of the configuration of the wheels and tires and the push rims, they can be almost too wide for that doorway. Many of those chairs run up close to 30 inches wide, and the ADA requires the door to be 32 inches wide. And if you can think of how a door sticks out with traditional door hinges, that makes the doorway quite tight for those chairs. One thing I would encourage is to install automatic systems at your entrances so that manual and power wheelchair users, as well as ambulatory persons with disabilities, can use the automatic systems to get through the doorways. If you do have a ramped entry, a rise over run of 1 to 12 inches is required, and that ramp needs to be 36 inches wide. Where you can minimize weather thresholds for manual wheelchair users, it's very difficult for them to negotiate over it. Many of my patients have neurological impairments, including hypertonia and spasticity. And when they hit those weather thresholds, the rough jarring of the system can cause their tone to be exacerbated, and it can affect their position in their chair, as well as can be a safety issue. So where you can minimize that is best. And then also ensure that you have adequate parking spaces that are close to the facility. And the rule or the law states that 2 adjacent spaces can be shared as long as there's an accessible aisle in the center that's of 60 inches. For interior hallways, we encourage you to limit clutter and provide strategic seating. We've removed a number of chairs from our lobby so that wheelchairs can have access and be positioned appropriately. Make sure the hallway is nice and wide. The rule or the law is 60 inches to allow for 2 chairs to pass each other. Use solid flooring material versus carpet. For manual wheelchair users, it's very difficult for them to propel on carpet of any pile. So even low profile carpet is challenging for them and their caregivers. Also, carpet's not very hygienic, and it can accumulate a lot of grime regardless of how often you clean it. And then we've had to go through our facility and in many instances eliminate interior thresholds that also were barriers as well and didn't necessarily serve a purpose except a transition from one flooring material to another. So that became very helpful. For exam rooms, provide a strategic space allocation. I know of a clinic where because they do see and recognize a lot of persons in wheelchairs and on stretchers, what they've done is they've allocated an exam room, a specific exam room for those that is in an area where the doorway is widened, the corners, and in the hallway there's a wider radius with a more of an open floor plan to allow those stretchers and wheelchairs to get into those spaces. The traditional exam room table is not very accessible for a wheelchair user. And so at least in one room, it would be encouraged to remove the traditional exam room table. And if you can, get access to an electric high-low exam table with a partial safety railing. That partial safety railing will allow a patient to feel safe when on the mat table, as well as they can use the railing to assist with their mobility. We use a lot of vinyl covered bolsters and wedges in our environment to help position patients for comfort during an examination. If you encourage your patient to move to and from their chair, the use of a transfer board is valuable. What that is, there's a picture on the next slide, but what that is a board that goes underneath the patient that kind of provides a bridge between their chair and the mat table. And then finally, they do manufacture offset door hinges that allow the door to be tucked behind the door jamb, which clears a little more space when the doors open. So here is a slide of a variety of pictures. In the upper left-hand corner is the offset hinge. In the center on the top is an example of a high-low mat table with a adjustable head support. On the upper right-hand corner is just a traditional vinyl wedge that we would use to help the patient sit up when being examined. Bottom left-hand corner is a bolster to place underneath lower extremities and things like that when you're doing your assessment. In the center on the bottom is a transfer board. So you can see it's just a small board that goes underneath the patient, and then the other end goes over to the mat table where the patient can effectively scoot across it. And then if you're ever in a position where you feel like a physical exam out of the wheelchair is valuable and important, and the patient is dependent, they do make hydraulic mechanical lifts that could help mobilize the patient out of the chair and over to, say, a high-low mat table or something like that. Additional recommendations for access to services: strategic and creative scheduling to ensure the space and resources available. If you know ahead of time that the patient will be coming in a wheelchair, you can have that space available for their appointment at that time. We've done a good job at implementing telehealth visits for people who aren't able to attend in person. So that's been a plus. If it's at all possible and your front desk has the ability to coordinate transportation for a patient, that is valuable. Sometimes they might need public access, public transportation to get to your facility. And then we use reminder systems for patients that include text messaging, phone calls, and emails to ensure that the patient remembers that their appointment is scheduled. For a bathroom, providing access to an adapted and supportive toilet seat riser or removable handrails is valuable. Most commercial toilets are appropriate height, but 17 to 19 inches is what's recommended. Ensure there's enough space surrounding the commode for the wheelchair to access. You can also install grab bars alongside the commode for support. Ensure the doorway is of optimal width. And one thing that we have ran into in the past, as an example, is weighted safety doors can be a challenge for not only wheelchair users, but ambulatory persons with disabilities. And they can also be a safety issue in that regard. And so considering that and deciding what's going to work best in the situation is appropriate. And then make sure the door opens outward, because what that does is allow for increased space in the bathroom for the wheelchair user. So the next slide is a number of photos. On the upper left-hand corner is just a toilet seat riser with handrails. The bottom left-hand corner is a picture of removable handrails on a toilet for someone to utilize when transitioning to and from. And then finally, on the right-hand side, I just wanted to present the picture where the sink, it's an open access sink underneath. And that allows for the wheelchair to move closer to the sink. If you do have open pipes underneath, one thing I would encourage you to do is protect them. I've seen people injure themselves on pipes as well as burn themselves on hot water inputs. So making sure that that's not a safety issue is important. So now on to common communication impairments. We, in the rehab setting, where we work with a lot of persons with neurological impairments, we see a lot of the aphasias, dysarthria, in the setting of Parkinson's, hypophonia, and then verbal apraxia. So some common strategies, we encourage people to use meditative practices for overcoming word blocks, as well as controlling their anxiety. When patients' anxiety increases, their ability to communicate becomes even more challenged. So with expressive aphasia, we use communication boards with simple yes, no prompts, numbers, pictures, or complete words and phrases that are appropriate to our setting. We allow time for the patient to respond and express that they can take their time in responding. We encourage them, as a matter of fact, too, especially when we recognize that their anxiety is increasing and they're struggling to find words. We consider alternative communication strategies, such as writing strategies when effective, and then signing and electronic communication devices specific to the individual. We find that utilizing fewer words in more general terms is valuable. And then we also like to avoid distractions such as noise or concurrent procedures when we're working with patients. For the hypophonia, we cue them to be loud. We use the acronym SLOB, which is slow, loud, over-articulate, and breathe. We encourage them to be patient and directly and respectfully ask to repeat if any of the communication is unclear. Additional suggestions when communicating are to control the environment and keep it quiet and well lit, use face-to-face communication and eye contact, and use active listening to expressively confirm any unclear responses. And here is just a resource with regards to architectural recommendations when constructing a space for meeting ADA guidelines. Thank you.
Thank you, Joe, and all the panelists. That was excellent. So much good information. And I did ask, oh, we have a question. What is the most common access barrier you have experienced in medical offices in your life? And that comes from Dr. Fields. So Stephen, Lane, and Dana.
This is Dana. For me, it's parking and getting on the tables in a medical provider's office. I saw a doctor for many years, but I liked her. I couldn't get on the table. I'd always take my personal assistant with me, but I really, really liked her, so I kept seeing her. But that was one of my most common barriers is parking and access to the medical table.
Stephen or Lane?
This is Lane, and my household has become chaotic, but my biggest barrier has really been access to completing intake forms, signing consent forms, and any paperwork that requires hand-eye coordination for reading or providing input.
Stephen.
This is Steve. Again, I don't have any physical barriers, so I can access the office in that regard. The barrier that I experience is when interpreters aren't there or not accessible. So that's where my communication needs come in. The other barrier I experience is when offices use video remote interpreting. So an interpreter is on the screen. And oftentimes clinics don't have great high-speed internet. And so the interpreter's call can be dropped, signs are frozen, et cetera. And that's where communication can get disrupted.
Thank you, all of you. Great insights. Dr. Hebely, go ahead. Unmute. Not done yet. There you are.
Can you
You're
hear
on.
me?
Uh-huh.
Okay. So my question is, I know this probably doesn't happen super often, but what's the best way to communicate with somebody who is both deaf and blind?
That's a great question. This is Steve. So you typically bring in an in-person interpreter who specializes in deaf-blind interpreting. In addition to that, you can use a certified deaf interpreter who uses tactile signs and certain body like mechanics and touches. So communication is pretty clear. Because sometimes you'll have folks who are low vision where they just need close vision interpreting, and other folks you do have tactile interpreting where you'll need a set of interpreters to accomplish that appointment.
And this is Lane. I will add to that it will depend somewhat on their communication preferences. Anyone who, well, a lot of people who were blind before losing hearing rely on text to speech and Braille technology combined, which often equates to having the provider type onto an electronic device. Sometimes it's an iPad where you're handed a keyboard and they use a Braille display and there's text communication back and forth. Other individuals may have dedicated devices where they lay a keyboard down over an Android tablet, and then when they need you to type to them, they flip that up and you type on the touch screen. So there will be a need to communicate with that person, probably at point of scheduling. They will usually communicate those preferences and be able to share that, but you can always ask the person who likely has someone supporting them initially, or they will have a way to communicate via telephone when they schedule.
Thank you. And obviously we're running late. I see 2 more questions in the chat. I'm going to go ahead and run through them if that's okay with the presenters. And Dr. Solberg, I think your question was answered kind of by Stephen about sign language interpreters acceptable to the patient. Are they acceptable to the patient. Did you feel like your question was answered when he was speaking before, Dr. Solberg? Or do you have something more specific? Go ahead.
No, that was it. I was thinking, out in small town, rural Idaho, there may not be sign language interpreters available, and our video sign language interpreters acceptable, and do they do a good enough job? Does it work, functionally work?
Yeah, this is Steve. That's a great question. I'm actually really glad you asked. In rural places in Idaho, honestly, rurality throughout the United States is a huge issue. We are noticing broadband speeds increase that allows for VRI to be a better option. Usually VRI interpreters are of high caliber. And so sometimes even locally folks will prefer VRI over in-person interpreters. And that is a great option to use.
Okay, great. Thank you. And then final question, and if you have others, you can email me. I'll put my email in the chat. You'll be getting all the resources that were discussed today, as well as a link to the recording of this video and the slide decks, just to let you know before we finish up. And Dr. Norb asks, do you have tips for how we can make each of you more comfortable with the physical exam portion of the visit? So let's wrap up with each panelist. Who wants to begin?
This is Dana. I think just talking to me like I'm a person. And it would be really great to have accessible tables. But, if I know what's going on, and you also listen to me, but I think that's most important. I feel pretty comfortable. If I don't feel comfortable going to a doctor, I kind of shop around. I'll go find somebody else. But once I find you, I'll stick with you forever until you get rid of me.
This is Steve. Personally, I think using the interpreter to explain, what you anticipate doing. So instead of, telling me to, okay, please undress now, explain what the purpose is that before asking me to do something. So oftentimes as a deaf person, I need the why behind what's happening. And so getting that explained to me before asking me to do something is going to be most important.
Mrs. Lane, I would say similar to Steve, explaining before proceeding with anything, and always notifying someone who is visually impaired or blind that that you're going to touch them, which is expected in an exam, but knowing where can be very helpful in reducing anxiety and putting someone at ease. And one thing that I experience in the physical space oftentimes is having someone in the office who thinks that they need to push me or pull me around the office to show me where to go. So understanding what human or sighted guide is and how, no, go put it in the trash, please. How to utilize those techniques so that you can guide someone without directing them is also very helpful.
Well, those were incredibly helpful insights. A fantastic presentation by all of our panelists. Thank you so much to the panel. I am so glad we've recorded this because I think it's going to be a really valuable resource for all IAFP members. It will be housed on our website. Those of you who attended will receive the recording, the slide decks, and relevant links. You'll receive your CME within 1 week. Please note that in the chat, I put the survey to evaluate the presentation tonight. I'd appreciate your feedback on that. Is there anything anybody on the panel would like to say before we finish?
This is Dana. Just thank you so much for inviting us. And Liz, I have a new updated slideshow because the one that I gave you got wrong information on it.
I will make sure I get the accurate ones from you and Joe and put those into PDFs to share. All right. Please note that educational programming is continuing throughout the fall for IAFP folks, and I put that schedule and links into that educational content into the chat. Thank you again, all, and everybody who attended tonight, and have a good evening.
Thank you, you too.
Okay, here's your chance. They went bye-bye.